Good morning, dear students. So we can start this session, and very first question is about elderly patient presenting with erythematous silvery scales, the scaly plaques over trunk and extremities for last 10 years. These are occasionally itchy, and they show remission, relapse with exacerbations during winters. So most likely diagnosis. Yes, all of you are correct. So I'd like to just add a few words, like the word erythematous means redness, right? And silvery scales, classical picture for psoriasis. Apart from that, what you will find few word remission. Now, anyone, what do we mean by remission? Improvement in a condition. So patient will feel that I am cured. So improvement in condition. And what does this word relapse means? Relapse means again worsening of the condition. So if you find the word remission or relapse, it means the condition is improving over some period of time, then again the condition recurs. And exacerbation means flaring up of symptoms. So these are few words which you should know. And of course, this is a very classical picture of psoriasis, where you can see the lesions over the extensor aspect. So you can see the lesions are over the extensor aspect, can be extensor aspect of forearm or back, right? The extensor aspect is one thing. Then second is, of course, there is a silvery scales, right? Then third is there is erythematous, means there is a redness around those scales. So this is a classical, spot diagnosis for psoriasis. So yes, the answer is psoriasis vulgaris. Then coming to the next question, tense blisters on flexor surfaces with anti-BPAG1 and anti-BPAG2 antibodies. This suggests the diagnosis of. Very good, Raghu. Very good. Yes, Neha, Priyanka. Fine. This is bullous pemphigoid. Now, for bullous pemphigoid, you have to remember few words. Again, the classical and the most important word is tense bully. Always remember tense bully. Now, what is this bully? Because there are two words, vesicles. There are two words you need to remember, and actually they differ in the size. So bulli are more than 1 centimeter in diameter, vesicles are less than 1 centimeter, and they are both clear fluid containing lesions. So vesicles bully, they are almost same pathology, but they just differ in size. So if you are having this word, it means the size of the fluid filled lesion is more than 1 centimeter, right? Then the other thing, it's like quite, if you see BP here, the BP word is actually bullous pemphigoid. So that also helps you in making the diagnosis of bullous pemphigoid. So there are antibodies against BPAG1 and BPAG2. Then another thing which you should know here is that there is a clinical sign known as Nikolsky sign. And any idea what is Nikolsky sign? Like it's positive or negative here? Very good, Raghu. It is negative in tense blisters, that is bullous pemphigoid, right? So it is negative. Now, any idea what is Nikolsky sign? Yes, Aninda, Neha, you're right. Rinkesh, you're right. So if we give a tangential pressure along the blisters, there is peeling of skin, right? And this Nikolsky sign is actually a clinical demonstration of acantholysis. It is clinical demonstration of acantholysis. Yes, Raghu, you are absolutely right. Okay. So Nikolsky sign is negative. Now, third thing which you know here is, what if we do immunofluorescence? What we see on immunofluorescence? Any idea? We will see linear deposits of IgG C3, right? So there is linear deposits of IgG and C3. So these are three facts which you should know for bullous pemphigoid. And of course, there are antibodies against BPAG1, BPAG2. And since it is a blistering disease, what is the IgG? Now, since it is a blistering disease, so what is the level of blister formation? It is dermo-epidermal junction. Yeah. So at the junction of dermis and epidermis. So if I draw it something like this, suppose this is dermis, and if this is epidermis, pardon, and here we have dermis, then the blistering is somewhere here, right? Somewhere here at the dermoepidermal junction. Now, why I'm putting these? Yes, Gulshan, subepidermal, very good. So it is, yes, you can say it subepidermal, below the epidermis. Perfect. Now, why I'm putting all those 4 points? Because these points are very valuable in differentiating bullous pemphigoid from which condition has to be differentiated from bullous pemphigoid? That is pemphigus, and especially I'll be more interested in discussing pemphigus vulgaris. So pemphigus vulgaris. Now in pemphigus vulgaris, what kind of bully will you see? Flaccid bully. Right? In pemphigus vulgaris, the right. So flaccid bully. So one thing, tense bully, bullous pemphigoid, and flaccid bully in pemphigus vulgaris. Number 2, now coming to Nikolsky sign. What will be the Nikolsky sign? Yes, Gulshan, right? We will come to that. What the Nikolsky sign is? Positive. Yes, so Nikolsky sign is positive, and as I told you, that is a clinical demonstration of the process of acantholysis. We will come to that later on. Now, what? Yes, very good, Raghu. On immunofluorescence, we will see fishnet pattern. Very good. Fishnet pattern of deposition of IgG, and very good. And what is the level of blistering? Yes, Raghu, absolutely. So this is suprabasal, or you can say intraepidermal. Okay. So there is suprabasal or epidermal acantholysis, right? So if I draw in case of pemphigus vulgaris, the blistering will be somewhere here. This is for pemphigus vulgaris, and this one is for bullous pemphigoid. Clear? So you can see the level of blistering. Yes, intraepidermal. So these are few differentiating points in bullous pemphigoid and pemphigus vulgaris. Apart from these 4 points, there are few other things which you should know for pemphigus vulgaris. Number 1, another thing, like on histopathology, you will see row of tombstones, row of tombstone appearance. And actually what happens, like we are saying that there is suprabasal split. So what happens, suppose if this is the basal layer of epidermis, the basal cells, they remain attached somewhat like this, and this gives rise to the row of tombstone appearance. This is row of tombstones appearance, and just above that we have all, you can say, acantholysis or blistering. So this is row of tombstone. Apart from that, you should also know what kind of antibodies we see in a case of pemphigus vulgaris. Any idea what? Yes, Raghu, there is mucosal involvement as well. So what kind of antibodies you see? Because in bullous pemphigoid we see anti-BPAG1 and AG2. Very good. So there are actually anti-desmoglein antibodies. So there are anti-desmoglein antibody, yes, anti-DSG3, and this desmoglein is a protein. It's a protein which is present in the desmosome. It is present in desmosomes. Yes, DSG3, totally right. So this desmosomes, actually it is the connecting protein which is within the keratinocytes. Suppose if these are keratinocytes, yes, so there is a connecting protein between the keratinocytes, and this holds the epidermal cells together. Now what happens? Now this is desmosome, and within this desmosome is the desmoglein protein. So if there is any antibody against desmoglein, actually it is going to break the desmosomes as such. What will happen once the desmosomes is broken? What will happen? The cells, they will move apart, okay, like this, and this is known as acantholysis. This is known as acantholysis. So you can see broken, right? Desmosome is broken and the keratinocytes, they move apart. So this is known as acantholysis. And if someone asks you what is acantholysis, you will say that there is loss of coherence or connection between the keratinocytes. And if we are discussing pemphigus vulgaris, it is suprabasal. And there is one more variant of pemphigus, that is pemphigus foliaceus. And in pemphigus foliaceus, the level of this acantholysis is subcorneal, right? Somewhere here, this is pemphigus foliaceus. So this is how things are differentiated, and at least for bullous pemphigoid and pemphigus vulgaris, one has to be very clear in the points of differentiation. This all point will summarize the important points you should know about these two conditions. And if you look at the clinical picture of bullous pemphigoid, and you can see the tense bully, of bullous pemphigoid, very easy to identify. And yes, as Raghu mentioned, we can also add oral, which is absent in bullous pemphigoid. It is present only in pemphigus vulgaris. So at least remember these few points out. Yes, bullous pemphigoid, elderly patient, tense bully. Yes, perfect. Right? So please remember this much. Now we come to another question. A pregnant lady with hyperpigmentation over face. So pregnant lady, yes, I think everyone can answer this. This is melasma, also known as proasma, right? So you can see this is typical presentation of melasma or proasma, right? Now, another question. A young lady presents with vesicular lesions in the buccal mucosa and flaccid blisters over the skin. What could be the diagnosis? Oral cavity involvement and flaccid blisters. The answer has to be yes, pemphigus vulgaris. So the moment you find flaccid blisters, oral cavity involvement, there is no other condition to entertain. It is pemphigus vulgaris. Oral mucosal lesions and flaccid. Yeah, this is pemphigus vulgaris. So you can see most of the blisters, they have already ruptured. Here you can see flaccid blisters, and sometimes there is rupture of the skin. This leads to denudation of. This is classical description for pemphigus vulgaris. Most of the things we have already covered for vulgaris. Now, what is this? Cobner's phenomena is not seen in. Any idea where we don't see Cobner's phenomena? Yes, everyone is correct. The answer is herpes simplex. Now, what is this Cobner's phenomena? Cobner's phenomena, everyone is correct. It is also known as isomorphic phenomena. Also known as isomorphic phenomena, and iso means same, morphic means morphology or appearance. What happens here? Yes, Raghu, yes. So the sequence is normal skin, then trauma, right? And post trauma, there is appearance of lesions over that normal skin. Clear? So yes, so normal skin, trauma, and appearance of lesions of that particular condition, whatever is in discussion. So we have three conditions: lichen planus, psoriasis, and vitiligo. So suppose if we are discussing about psoriasis, it means there will be appearance of psoriatic. Whatever the condition we are discussing, if there is any over the normal skin, that will promote the appearance of new lesions. And this picture you can see. So patient with psoriasis went for tattoo, and later on that area developed psoriatic lesions, and you can classically see two important things. You can see erythema, that is redness, and you can see silvery classical presentation for psoriasis. So this is actually Cobner's phenomena or isomorphic phenomena, but this is not specific only to psoriasis, lichen planus, as well as vitiligo. Yeah. So this is just to define what isomorphic or Cobner's phenomena. And in relation to this, sometimes there is one more word, and that is known as inverse Cobner's phenomena, reverse Cobner's phenomena. What happens here? Right. So what happens? There are lesions, then trauma, and disappearance of lesion. This is inverse or reverse Cobner's phenomena, where injury might lead to disappearance of lesions, can be seen in psoriasis. Right. So there are two terms, but please remember Cobner's phenomena, and that is not a specific. Now coming to next question. A young male presented with pruritic, flat-topped, polygonal, shiny, violaceous papules on flexural aspects. What is the likely diagnosis? Very good. So this is a classical presentation for lichen planus, and one must remember the 5 P's of lichen planus. What are those 5 P's? Everyone is right. This is lichen planus. What are those 5 P's? Okay, yes. See reticular pattern in oral cavity. Good. regime in nail. So what are the 5 P's of lesions of the skin lesions of lichen planus? One is of course the color, that is purple, or what we say violaceous. The second P is pruritic, means there is severe itching. Then third P is plain topped, means flat from above. And fourth P is polygonal, right? So geometrical configuration can be polygonal. And what is the fifth P? Papule. Very good. So what is this word papule? Any idea what is this word papule? Anyone? Papule. See, again there are two terms. One is papule, another is plaque. The size of papule is in 1 centimeter, plaque is 1 centimeter, and we define them as raised in clear. Papule means that the size of the lesion is going to be less than clear. So these are the 5 P's of lichen planus, and you can see classical lichen planus, especially involving the flexors area. So you can see this is the flexor aspect of the forearm, right? And there might be lacy markings in oral cavity associated. Marking, and yes, flexor aspect. And second is you can see victim try on the top of the lesion stripe. Then third, these are additional features which you should remember. Right? Please remember this much for lichen planus, and it is very easy to make a clinical diagnosis in planus. Now coming to the next question. Yes, civet bodies, right, Nidhi? Coming to the next question. Male presented with painful grouped vesicular eruptions, and he have a history of similar lesions in past 1 year. What can be the diagnosis? Very good, very good. Everyone is right. This is herpes simplex virus 2, and the condition is actually herpes genitalis. This condition is actually herpes genitalis, and if you look at the image, you can appreciate grouped vesicular lesions. They are in a group, and importantly you can see there is redness. There is redness around the lesions, so this is known as erythematous phase. So related to surrounding all vesicles, there is redness, and redness, you can see redness all around the vesicle, and they are always in a group. So important is for herpes, the important thing is that group vesicles, we discussed less than 1 centimeter, clear fluid filled lesion. Okay. And there is erythematous phase, so redness can be seen. Okay. And they mostly we find all these vesicle groups. That is very specific for herpes. And since this is a high friction area, so at times there might be rupture of these vesicles, and patient might come to us with ulcers. Pulsion, yes, painful in Ducray, but it can be in multiple. Very good, Pratyusha. Right. So this is very classic of herpes genitalis. And what drug you need to give? Any idea what drug you need to give? Isoclone. Yes, right, Pratyusha. So this is herpes genitalis. Now, next question. A young male patient presents with mild urethral discharge. What should be given to treat such a patient? I think one should just make sure that whether it is 1 gram or 1 milligram. Of course, it is single oral dose. This is SOD, that is single oral dose, right? So the answer is 1 gram single oral dose or 1 gram stat. Now, what is the clinical condition? What is the diagnosis? You tell me, what is the diagnosis? Anyone, what is the diagnosis? You are treating the patient rightly, but you should know what's the diagnosis. Anyone? Diagnosis? See, urethritis is a broad term, right? Urethritis or urethral discharge is a broad term, and in this, very good, in which we discuss two conditions. One is gonococcal urethritis and another is non-gonococcal. Yeah. So gonococcal, as the name suggests, it is because of Neisseria gonorrhoeae, and non-gonococcal is cause of chlamydia. Right? So this is a classical picture of non-gonococcal urethritis, right? And how we clinically differentiate? We look for the kind of discharge. In gonococcal, it will be, in gonococcal, what kind of discharge you see? Purulent, right? Purulent, thick, yes, purulent, thick. Whereas in case of chlamydia or non-gonococcal urethritis, the discharge is watery, thin. So the kind of discharge actually tells us about the probable diagnosis. So here, since it is mild urethral discharge, we can assume it to be a case of non-gonococcal urethritis, which is caused by chlamydia, and we will give azithromycin 1 gram single oral dose. Yes, of course, for gonococcal we will give cefixime. So this is in short about the urethral discharge. I think all of you must be knowing what in syndromic approach of PDs, what kit we give for urethral discharge. What kit? Yes, gray kit 1. Very good. Gray kit 1. And what drugs it contain? Yeah. So this is for urethral discharge. Now, moving forward to next question, Auspitz sign. What is this Auspitz sign and where we see? Yes, this is seen in psoriasis vulgaris. Now, what is this Auspitz sign? Any idea what is Auspitz sign? Very good. So we know that in psoriasis there are silvery scales. There are silvery. If you try to remove these silvery scales, this will lead to pinpoint. Yeah. So the simpler explanation for Auspitz sign, removal of the scales leads to pinpoint bleeding. So classical, you can see pinpoint bleeding after removal of scales. So this is Auspitz sign, very suggestive of psoriasis. And if we go for the exact process, then you can recall one Gratis test, right? And when we remove the silver scales with the edge of a slide, there is appearance of alkalis membrane, and once this membrane is also removed, we will find the pinpoint reading points. So this is the actual description, but in this Gratis test. So, but in shorter terms or in simpler words, we will say that removal of silvery scales will lead to pinpoint bleeding, and that is also psoriasis. Perfect. Now coming to next question, spaghetti and meatball appearance. Any idea? Spaghetti and meatball appearance. Yes, this is Malassezia infection. And what condition we are discussing? Any idea what condition we are discussing here? Very good. So this clinical condition is pityriasis versicolor, or also known as tinea versicolor, which is caused by Malassezia furfur. And what actually we see here, we will see rounded forms. Okay, these are the meatballs, and we will also see the elongated forms, which are actually the spaghetti. Spaghetti and meatball appearance, and sometimes it is also known as banana grape. Just because of those looks, it is also known as banana and grape appearance. Yes, right. So spaghetti and meatball and banana and grape. Now, next question. There is, we need to correct this. We placid. So there is a history of placid bully with oral ulcers, and if you do microscopy, what you will see? Yes, very good. The condition is perfect. The answer would be acantholytic cells. Diagnosis, clinical diagnosis, pemphigus vulgaris, and if we prepare a Zank smear, we will see an acantholytic cells. So now, what acantholytic cells look like? So you will see a rounded cell, and you will see a large acantholytic. Okay, so these are actually the keratinocytes. Yes, Solon cells. Yes, on Zank smear. Zank smear. So the keratinocytes, they become swollen, they are rounded, and these are known as acanthocytes. And in this image also, you can clearly see the acantholysis. This is acantholysis. You can see that there is so much of gap between the keratinocytes. Normally, the keratinocytes in the epidermis, they are very tightly packed because of desmosomes. But here you can see there is gap, and this is known as acantholysis. So this is acantholysis, and since it is seen within the epidermal layer, so it is known as intraepidermal acantholysis. Clear? So acantholytic cells on Zank smear in a case of vulgaris. Next question. There is a family history of asthma. Now the patient has presented with itching in cubital fossa and popliteal fossa. Most likely diagnosis. Now here you have to this one word, asthma. Yes, very good. So the moment you find the word asthma or any allergic condition, the answer is atopic dermatitis, and you can see there is so much of itching in the popliteal fossa. There is so much of itching that led to coriation of the skin. Is classical picture of atopic dermatitis, and since there is so much of itching, this condition is also known as itch. So itch disease, and there is always a family history of asthma. And apart from that, what else you can see, there is one important finding in lower eyelid. What is that? Is atopic condition, so type 1 reaction. What you will see in eyelid, especially in lower eyelid, you will see an morgal line, and right, and how the diagnosis is made. Any idea how diagnosis is made? Danny Morgan folds. The diagnosis is always clinical, right? So you have to take the history, and based on that only you will make the diagnosis. And we use one criteria, is Nifin and Kajka criteria. So the diagnosis of atopic dermatitis has to be always to be clinical, based on the presentation of the patient, and we use one. So this is enough for dermatology. We can take a 15 minutes break, and then we will start with physiology. See you after 15. Welcome back, dear student. Now we will discuss questions of physiology. And the very first question is about fluid transporters. Now, basolateral membrane of the intestinal epithelial cell contain which type of fluid glucose transporter? Any idea? Now here you need to remember one thing, that in intestinal epithelial cells, depending on the location, whether it is apical or basal, we have different fluid glucose transporter, right? So in basolateral membrane, yes, Vicky, Rinkesh, perfect. So it is glut, right? So if I draw a epithelial cells thing like this, so this is the apical part, and this is right. So in apical part, we have a different glucose transporter, and in the basal part, we have a different glucose transport. So in basal is GLUT2, whereas in apical is GLUT. Clear? So please remember this and don't mix up. Yeah. So GLUT2 in basal part and GLUT5 in apical part of intestinal epithelial, and here we have all lumen of gut. This is gut. So remember GLUT2 in basal part of the epithelial cell. Now, first site of hematopoiesis in a fetus. So hemato means blood, poiesis means formation. Yes, hemato is blood, poiesis means synthesis or formation, and the first part is yolk sac. After yolk sac, if I write the sequence, yolk sac is first, followed by liver, very good. After liver, in terms of, you can write spleen, and lastly it is clear. So this is the usual sequence, and you can make a mnemonic out of this, like some people decide to make a mnemonic something like this, right? So this is the sequence: yolk sac, liver, spleen, and bone marrow. And of course, if spleen is not given, then directly go for. So this is the usual sequence. Next question: which of the following gases has got the highest affinity for hemoglobin? Yes, anyone? Highest affinity for hemoglobin? Perfect, perfect. So this is carbon monoxide, and so carbon monoxide has got highest affinity for hemoglobin, right? And which kind of anemia will this result? Yes, perfect. What kind of anemia you will find? Any idea? This is which type of hypoxia? I'm sorry, hypoxia. This is anemic. This is anemic hypoxia. And why I am saying so? Because what happens in anemic hypoxia, or even in like anemia, usually in anemia, the usual thing is that there is decrease in hemoglobin, and since the hemoglobin is the carrier protein for oxygen, so there is less oxygen content in blood. Clear? So this is the usual pathology in anemia. Since oxygen cannot travel by its own. Majority it binds with the hemoglobin. So in anemia, hemoglobin is less. So as a result of this, the content of oxygen in the blood is also less. Now the same kind of picture is seen with carbon monoxide poisoning. Hemoglobin, it was normal here, but since it binds with, or you can say carbon monoxide binds with hemoglobin, so very less is available for oxygen. Very less is available for oxygen, right? And whatever the content of oxygen in blood is actually the one which we measure as hemoglobin O2. So it means less hemoglobin for oxygen, it means less oxygen content in the blood, right, in relation to the bonded form with hemoglobin. So that gives a picture of anemic hypoxia, because the carrier protein is not available to transport the oxygen. So this is a kind of anemic hypoxia. So carbon monoxide poisoning will give you a picture of anemic. Clear? Because some students, they might at time get mixed up with histotoxic. It's not histotoxic, it's anemic. Cyanide is histotoxic. Perfect. Now next question. First heart sound coincides with which phase of cardiac cycle? Yes, everyone is correct. This is start of isovolumetric contraction. Now what do we mean by this word isovolumetric contraction? Iso means same, right? Volumetric means the volume of blood, and contraction is of course the contraction of ventricle. Now what is that condition when the ventricle is contracting but still the volume of the blood in the ventricle is same? That can happen only if both the valves above and below are closed. So suppose if we are talking in terms of left ventricle, you can say that it is mitral valve is closed, and lower down it is aortic valve is closed. And when the left ventricle is contracting as a closed chamber, right? So this is IVC for left ventricle, IVC of left ventricle. So that is the concept of isovolumetric contraction. The valve above is closed, the valve below is. So when the atrium is contracting, the blood will be pushed from the atrium into the ventricle. After that, it is the left side, the mitral valve will close, or if it is the right side, the tricuspid valve will close. So after that, AV valve will close, and that will produce the first heart sound. Semilunar valves are already closed, so the valves above and the valves below both are closed. Now the ventricular cavity is a closed chamber, and when it will start contracting, that will be known as isovolumetric contraction. So the first heart sound ends with beginning of isovolumetric contraction. Yeah. So remember this. Now third heart sound is heard because of. Yes, third heart sound. Yes, Raghu, Rinkesh, Nidhi. Yes, this is mid diastolic flow in the ventricle. Now, when the ventricle is in diastole, it will receive blood. Right? It will receive blood, and there are two phases. One is early phase, early rapid filling, and second is the late filling phase. Now this late filling phase is because of atrial contraction. Yeah. So this early rapid filling phase will produce the third heart sound, and this atrial contraction will produce the fourth heart sound, right? So if someone asks you what is the cause of third heart sound, then you will say that it is the early rapid filling phase of ventricular diastole. Yeah. And atrial contraction, this will give you S. Clear? This AV valve is S1, semilunar is S. Right? Remember it, something like this sequence. I guess everyone is clear in this. So third heart sound, it is early rapid filling phase of ventricular diastole. Now, next question, large V waves are seen in which condition? Large V waves. Okay, good. Yes. So this is tricuspid regurgitation. Now let us discuss the different waves of JVP. So JVP has got positive waves and negative. Positive waves are seen if there is increase in blood flow in the right atrium. JVP is actually reflecting pressure changes of right atrium, right? So increase in blood flow or increase in, and if you reverse the facts, it will be the negative waves. Decrease in blood flow, or you can say in simpler terms, you can write outflow. Outflow will be better. So increase in outflow from right atrium to right ventricle, or decrease in pressure, which we will see in cases of atrial relaxation. So these are the, yes, so these are the points which are associated with positive waves or negative waves. Now there are three positive waves, A, E, B, and two negative waves, X and here. Three positive waves and two negative waves. Now what is the reason for positive wave A? A is because of right atrial contraction. Here, so there is right atrial contraction. Then we'll take V first. V is because of increase in blood flow in right atrium. Yes, right. So V is because of increase in blood flow in right atrium, and in between the two, there is one positive C wave. So these are all positive waves. So this is because of bulging of tricuspid valve because of right ventricular contraction. Clear? So this is the reason. Yes, you can write it venous filling. Same thing, right? So these are the reasons for the positive waves in JVP. Now we'll go to the negative waves, X and Y. X is because of atrial relaxation, right? If there is contraction, there has to be relaxation. And Y wave is because of flow of blood from right atrium, right. Clear? So this is the description for the waves of JVP. Of course, these are the negative. Now we'll come back to the question proper, which is about large V waves. So it means it is asking about V waves, and V waves is about the flow of blood within the right atrium or the venous filling of the right atrium. Now what happens in cases of tricuspid regurgitation? Suppose this is tricuspid valve, and above there is cavity of right atrium, right atrium, right ventricle. Now usually the blood is coming from vena cava, superior and inferior. Right? So it is coming from superior vena cava. So this blood is already coming into the cavity of right atrium, but there is additional amount of blood which is coming from right ventricle because of tricuspid regurgitation. So the amount of blood within the cavity of right atrium is more, and therefore, in simpler words, if the venous filling is more, V wave is going to be more prominent. So larger V waves, tricuspid regurgitation. Please remember. Okay. Then next question, GLUT2 transporter, what is the location? We have already discussed one in the basolateral membrane of intestine. Now out of these all options, which is the location for GLUT2 transporter? Yes, anyone? Very good. So the answer is liver. Apart from liver, apart from intestine, liver is also an important place for GLUT2 transporter. So for GLUT2 transporter, you can remember the mnemonic LPS, that is the levator palpebrae superioris, and write LPS here. So L is for liver, P is for pancreas, initially beta cells, and S is for small. Again, this is basal part. Clear? So for GLUT2, you can remember these three things at least, LPS. And for another important which everyone should know is the GLUT4. And for GLUT4, you can remember the mnemonic SAC. Here you can remember the mnemonic SAC. S is for skeletal muscle, A is for adipose tissue, C is for cardiac muscle or myocyte. So at least remember these two, LPS for GLUT2 and SAC for GLUT4. And what is more important, this is insulin dependent. Please remember the GLUT transporters, because this is a very favorite question for exam setter. And GLUT5 we have already discussed in the spical part, epithelial cells. Please remember this. Yes, Pratusha, right. Insulin dependent. Now, next question. Again, based on JVP, what finding in a case of cardiac tamponade? What finding in cardiac tamponade? Very good. Absent Y descent. Now, what is cardiac tamponade? There is collection within the pericardial sac, right? Yes, prominent X. There is rapid collection in the pericardial sac, and this hampers with the normal physiology of the heart. This is cardiac tamponade. Now, what does the word tamponade means? Tamponade means actually pressure effect. So that collection, yes, backstride, very good. So that collection is actually pressurizing upon the, therefore it is affecting the normal physiology of heart, and we will find a prominent X and an absent Y descent. And what was the reason for Y wave in JVP? Y wave in JVP, the negative wave, because of flow of blood from right atrium to right ventricle, right? So absent Y descent in cardiac tamponade. Of course, back tried, yes, it down, right? One is low blood pressure, and is muffled heart sounds. It will be, yes, it will appear as if the heart is beating at a very distant place. So muffled heart sounds, because the collection which is around the heart is a poor conductor of sound. And third is, of course, raised jugular venous pressure. Yeah, this is the back triads for cardiac. Anyway, please remember, absent wire descent and a prominent. Now, next question, tall T wave. So, tall T wave and a wide QRS, increased PR interval. All this goes in favor of, yes, I think everyone is right, hyperkalemia. Now, hyperkalemia, what is the normal value for serum potassium? 5.5 pulse equivalent per liter. Right? So whenever we are saying hyperkalemia, so the value will be more than 5.5 pulse equivalent per liter. Yeah. Good, Raghu, good. Now, as soon as the value increases, there is all entered T waves. So this is in fact one of the earliest manifestations on ECG in a case of hyperkalemia. Tall tented, tall peaked T waves, you can write, and then wide QRS. Wide. And if I say wide QRS, what is the normal duration for QRS? More than, normal is 0.08 to 0.1, so 0 or 0. And treatment wise, what we can give? We can give insulin plus dextro. Why insulin? Yes, Pratyusha, you are right. Why insulin? Because insulin promotes intracellular movement of potassium. But at the same time, insulin can cause hypoglycemia. Therefore, you should also give dextro. Otherwise, if you give plain insulin, a patient might develop hypoglycemia. So, dextrose is given to counteract hypoglycemia because of, clear? This is a little bit about hyperkalemia. Now, what clinical manifestations can occur because of hyperkalemia? There can be cardiac arrest can occur. So just remember this much for hyperkalemia, which is one of the important topics in imbalance. Arrhythmia, yes, cardiac arrest. Now LH, next question. LH, Susha, you are right. LH surge, what you will see? There is increase in estrogen and there is low progesterone. Now, if you remember, LH surge means there is a peak in LH value, and this occurs just before ovulation. So this is which phase of menstrual cycle? This is which phase? Follicular phase. And in follicular phase, estrogen is high, progesterone is very good. Progesterone increases in luteal phase. If I show you with a diagram. You can see here, this is the LH surge, and you can see raised estrogen, and you can see low levels of progesterone. So LH surge associated with raised levels of estrogen, progesterone levels are usually here. So this is LH surge. And here one more thing, whenever we talk about ovulation, what is the time period for ovulation in a menstrual cycle? Yes, perfect, Patricia, perfect. It starts around 24 to 36 hours we're here, and just speaks about maybe around 10 to 12 hours before the ovulation. Now ovulation, whenever we count it, we always count it with respect to the next cycle. So what we will say, 14 days before the onset of next. Yeah. So this period is constant. This period is constant, and this period is variable. Clear? So always and always, it is always safer to say 40 days before next cycle. Yeah. This is the period of ovulation. Now, coming to the next question, galactokinesis. Galacto is for milk, kinesis is, you can say, movement. Any idea? There are two terms, galactokinesis and galactopoiesis. Everyone is correct. So this is oxytocin, and this is released from posterior pituitary. Answer is right. So if I use the word galactopoiesis, for galactopoiesis is milk production. This is under prolactin. And if I say galactokinesis, this is milk ejection, and this is under effect of. Please read the word properly before answering. And yes, this is from anterior pituitary. And for oxytocin, it is synthesized in hypothalamus. It is formed in hypothalamus, and through the hypophyseal portal system, it is sent to posterior pituitary for storage. And once there is appropriate impulses, it is released. Yeah. So this is for oxytocin. Very good, Raghu. So please remember this in terms of breast milk, right? And for prolactin, it has a positive factor, is promoting its release, and there is an inhibiting factor which can affect the release of prolactin. So TRH promotes the release of prolactin from anterior pituitary, whereas dopamine, it opposes the release of. Now, insulin mediated GLUT4 transport. We already discussed that GLUT4, it is present in sac, so skeletal muscle, adipose tissue, and cardiac muscle, and this is insulin dependent. Yeah. And this is which type of transport? Yes, very good. So facilitated diffusion. Now, what is this word diffusion? What do you mean by the word diffusion? Diffusion means there will be movement of a particle from high concentration to low concentration. High concentration to low concentration, and since this flow is in accordance, yes, high to low. Nidhi, very good. So since it is in accordance with the simple principle, if there is high to low, it means there is no energy required. So no energy is required, and this is actually passive diffusion. Right? Active thing requires energy. So this is passive diffusion. There is no requirement of energy along the concentration gradient. Yes, perfect. And in facilitated, now what is this word facilitated? Facilitated means, in simpler words, you can say promotes. So facilitated diffusion, it means it will promote the diffusion along the concentration gradient. Yes, of course, using carrier proteins. So this is facilitated diffusion, which is a sort of passive transport. Yes, Raghu, you are absolutely. So GLUT4 insulin mediated transport is actually facilitated diffusion. Please remember. Next question. Uterine contractions results in cervical dilatation and followed by delivery. Same mechanism is also noticed in yes, Pratusha, you are right. So this is milk ejection reflex by oxytocin, because both the phenomena are carried out by, so uterine contraction is also because of oxytocin, and this is also because of oxytocin. These are the same effects at different locations. Now, a lady delivered a baby, but she is not able to breastfeed because there was no milk production. Now, which of the hormone is inhibiting milk production? This we have already discussed, because whenever we say milk production, we are talking about which hormone? We are talking about prolactin, right? And we discussed that prolactin is inhibited by dopamine from thalamus. This is yeah. The answer is very straightforward. This is dopamine, right? So this is dopamine. Prolactin is inhibited by dopamine. Now, next question. Which of the following has nothing to do with serum calcium level? Answer is very straightforward, I guess. Anyone? No active role of insulin as such. Now, parathormone, it is released from gland. Yes, everyone is right. So this is released from parathyroid glands, okay. And the function of parathormone is to increase serum calcium levels. And how it increases the serum calcium levels? By promoting classes, promoting calcium. Clear? Now, what is this osteoclasis? This is bony absorption, because we know that the bones, they are the bank, calcium bank. So there is a continuous withdrawal of the calcium from the bones. There is absorption of calcium, and that is known as osteoclasis. So parathyroid hormone, it promotes that activity, and it to increase the serum calcium level. Now, what is this calcitonin? What is calcitonin? Okay, right. Coming to calcitonin, what is calcitonin? Is released from which? What is the source of calcitonin? Anyone? Calcitonin, it is released by, yes, it will decrease calcium levels. Yes, decrease. It is released from, what is the source of calcitonin in the body? Very good. So this is T cells, which are also known as parafollicular cells, known as parafollicular of thyroid. Yeah. So it decreases serum calcium level and principally is decreases to acid. Yes, yes, perfect. So parathormone and calcitonin, they are antagonists of each other. One tries to increase the serum calcium level, other tries to decrease the serum calcium levels. And just remember this much about parathormone and yeah. So insulin not discussed. Which of the following is reabsorbed almost completely in PCT? Yes. Which of the following is 100% reabsorbed from the kidneys? Perfect. The answer is glucose. Glucose is reabsorbed 100%, and there are two 100% reabsorption is two things. One is of course glucose, and what is another thing? Amino acids. Yeah. So these two are 100% reabsorbed. They should not come in urine in a normal person. Glucose and amino. Next question. Main role of angiotensin 2. Main role of angiotensin 2. And yes, we are talking about the renin angio aldosterone or axis. So the correct answer is increase in total peripheral resistance. Right. Now, what is the ultimate effect of this renin angiotensin aldosterone system? It tries to increase the blood pressure. Right? So the ultimate effect is to increase blood. Yeah? Yes, vasoconstriction. Yes, to increase blood pressure. Now it involves series of steps. Whenever there is hypotension, so the initial is angiotensinogen, which is coming from liver, and this is acted upon by renin, and it is converted into one more inactive substance, that is angiotensin 1. Now this is inactive. Clear? Angiotensinogen is also inactive, and we know that all the proteins are synthesized in liver except gamma globulins. So angiotensin 1 is also inactive. Now this angiotensin 1 is acted upon by ACE enzyme. So it is acted upon by ACE enzyme, and it is converted into the active form, that is angiotensin 2, and this occurs in, this is synthesized in lungs. So angiotensin 2 is formed, and this is active form. So it will do two work. It has two actions. Number one, it will promote release of aldosterone, and number two, it will cause vasoconstriction, or in simpler words, it will increase the total peripheral resistance. Right? Now this aldosterone, what is the effect of aldosterone? It will promote increased water sodium resorption. Right? Is water and sodium resorption. So this all will ultimately lead to increase in blood pressure. Now, how this concept can be correlated clinically? Because if you know that we use ACE inhibitors for treatment of hypertension. So if we use any drug which inhibits ACE, and this will block this cycle, and there will not be increase in blood pressure. So that ACE inhibitors or pril kind of drugs, captopril, lisinopril, ACE inhibitors, they block this particular part, so they prevent conversion of angiotensin 1 to the active angiotensin 2, and therefore this whole cycle cannot be completed. The blood pressure does not increase at all, right? So that is the clinical correlation of this whole cycle. So here the ACE inhibitors will act. Yeah. So this is renin, angiotensin, aldosterone class. Yes, Nidhi, you are right. Now, next question, inulin clearance. Don't mix it up with insulin. This is inulin clearance. It closely resembles GFR. Yes, good, Raghu. And whenever we are using any substance, so the ideal substance to measure GFR should have at least two properties apart from being safe also. Number one, it should not be reabsorbed, right? And number two, it should not be secreted. So it means none of the substance should be taken back from the kidney, or none of the substance should be given by the kidney. So that way, whatever the amount of that substance is coming out, that will be equal to the GFR. So that is the ideal property of a substance if we are using it for measurement of GFR. And yes, safety should be first, it should not be toxic to the humans. So inulin closely resembles GFR because neither it is secreted nor it is reabsorbed. So it equalizes GFR. Now, next question, if someone has taken a high carbohydrate diet, what will happen to the hormones which are concerned with the metabolism of glucose? So what will be seen after a carbohydrate rich diet? Yes, anyone? Yes, perfect. The answer is decrease in glucagon and increase in insulin. Now, if somebody is taking carbohydrate rich diet, what will happen? This will lead to increase in blood glucose. And how body tackles raised glucose levels? By promoting insulin and decreasing glucagon, because it is hyperglycemic hormone. So glucagon levels will be less, insulin levels will be high, which will avoid hyperglycemia, which has resulted because of increased intake of carbohydrates or in the form of carbohydrate rich diet. So whenever there is hyperglycemia kind of picture, insulin levels will be raised, glucagon levels will be low, and this will make sure that the blood glucose are within the normal range. It doesn't increase too much. So this is the usual hormonal. Yes, right, Pratyusha. Now next question, secretin. What is the best stimulation for release of secretin? Yes, anyone? Very good, Raghu, very good. So it is, the main is acidic chyme. Sorry, main is acidic chyme. Now here we can take the clinical picture first. Now, what happens? Suppose stomach, then duodenum. What happens? The stomach is very well developed to tackle the acidic environment. So here we know that HCl is there, which is very acidic, but the duodenum doesn't have an inherent mechanism to tackle this acidic thing. What happens? As soon as this acidic chyme enters into the duodenum, there is possibility that this acid might injure the duodenal mucosa. So this acidic chyme can injure the mucosa of the duodenum, and therefore we see that there is possibility of duodenal ulcer. Right? So what happens? There is a nature's mechanism to prevent this acidic injury to the duodenum, and that is in the form of here. So secretin is also known as nature's. So whenever the acidic food comes into duodenum, there is a reflex signal which goes to the S cells of the intestine, and they release secretin, and secretin, it promotes release of watery pancreatic secretions, which will neutralize acidity. Right? So this is actually alkaline. Right? So this is to neutralize the acidity of the acidic chyme. So this secretin, yes, increases bicarbonate. Yes, so actually bicarbonate. This is the non-enzymatic part. We know that pancreas is both exocrine as well as endocrine. So this is non-enzymatic part, and this just is alkaline, so it just tries to neutralize the acidity of this acidic chyme, and this prevents injury to duodenum. So please remember this much: secretin, the main function is to neutralize the acidic thing, whatever is coming to duodenum, and this also prevents the injury to the duodenal mucosa because of that acidic content. Right? So secretin is nature's antacid, and released by S cells of small intestine. Clear? So acidic stuff is the main stimulation for release of secretin. Next question: Brown-Séquard syndrome. So sensation lost on the same side in Brown-Séquard syndrome are all except. Yes, anyone? So Brown-Séquard syndrome, which is also known as hemisection the spinal cord. Now, when I say hemisection, it means half of the spinal cord is damaged. Now, to understand this particular question, we should know the anatomy of the spinal cord first. So, suppose if this is spinal cord is anterior, so here we have dorsal column. The shell is the dorsal column, and here we have lateral spinothalamic lateral spinal. So this is the arrangement. Fasciculus talis, and now we should know what modalities are carried by these ascending tracts. Now these are ascending tracts. So dorsal column carries what sensations? Yes, you are right, Pratyusha. Medially is fasciculus gracialis, laterally is fasciculus. Dorsal column carries which modalities? One is proprioception and another is stereognosis and vibration, fine touch, 2-point discrimination. Now these are the modalities which are carried by the dorsal column, and fasciculus gracialis is for lower limb and fasciculus cuneatus is for upper limb. Clear? It means the proprioception, stereognosis or vibration from the lower limb will be carried by fasciculus gracialis, and from the upper limb it will be carried by fasciculus cuneatus. Number one. Number two, what about decussation? Decussation occurs at the level of medulla. Clear? So the first order neurons of the dorsal column, they ascend till the medulla and then they change over their direction and they ascend as the medial lemniscal system till thalamus, right? So decussation occurs in medulla. Perfect. Now we'll take the another tract, and that is spinothalamic tract. Spinothalamic. I'm more interested in lateral spinothalamic tract. LST. What are the modalities which are carried by lateral spinothalamic tract? I'm more interested in discussing lateral. Lateral carries pain and temperature. Right, Raghu. So pain and temperature are carried by lateral spinothalamic tract. And now even more important thing is about the decussation or crossing over. What is the point of decussation of lateral spinal? Where we see the decussation. What is the point of decussation of lateral spinothalamic tract? Very good. It is at the level of spinal cord only. Clear? Now, we discussed these two important modalities and the level of decussation. Now we can discuss the clinical entity as such. So suppose if this is the left side of the patient, this is the right side of the patient. Okay. Now if there is complete injury to the left half of the spinal cord, there is complete injury to the left half of the spinal cord. It can be because of chop wounds or bullet injuries. So now what will happen? It will involve the spinothalamic tract, the lateral spinothalamic tract, and it will involve the dorsal column. Now the dorsal column modalities which are affected on the left side are actually the one which is taking the impulses from the left side only, right? So this one is from the left side only. So whatever the modalities which are going to be affected on the same side are the one which are carried by the dorsal column. Now here the lateral spinothalamic tract which is injured, it is actually the one which has come from the other side and then has crossed, right? So the lateral spinothalamic tract which is present on the left side is actually the one which is coming from right side, and since it has crossed at the level of the spinal cord only, so it will be affecting the sensations of the opposite side. right? So opposite side is lateral spinothalamic tract. Clear? Same side dorsal column, opposite side lateral spinothalamic tract, because the decussation or the crossing over has occurred at the level of spinal cord only, and if half of the spinal cord is injured, it means it will affect the fibers lateral spinothalamic tract which are actually taking the sensation opposite side. Clear? So opposite LST, same dorsal column. So the answer you can write is pain. Right? So this is the basic description for this entity which is known as Brown-Sequard syndrome or hemisection of the spinal cord. So you just need to know the course of the tract and the modalities which are carried by them. So what is this proprioception? Any idea what is proprioception? Any idea what is proprioception? This is joint, yes, joint position sense. If suppose if we close our eye and if someone manipulates our joint, we can identify that what position our has been given to our joint. So that is joint sense. What is stereognosis? Any idea what is stereognosis? Yes, Raghu, you are right. Stereognosis. Any idea? Stereognosis means if suppose if we close our eyes and if there is no auditory input and if somebody gives some object in our hand, we will simply feel it by the fingers and we can answer that this object has been given in my hand. Suppose if I given a pen, I can simply roll it in between my fingers and by the touch only I can say that this is a pen. So that is known as stereognosis. Yes, identifying object without any auditory or visual hints. Right? So proprioception and stereognosis. Anyway, so next question. Atrial and saccule in the inner ear. Yes, many of you have already answered that. It is linear acceleration, and yes, for angular acceleration, this is semicircular canals. Perfect. Now, next question. Yes, right, semicircular canals. If there is a damage to a brain structure, after which there is less appreciation of fear, which structure might have been damaged? Yes, amygdala, right. So amygdala, this is for perception of the fear, and if amygdala is injured, the person might become fearless, so he won't appreciate the fear, right? So this is about amygdala. So response related to fear. Now next question. Elderly patient with a history of stroke, now having stroke involving the inferior frontal gyrus, what would be seen? So there is injury or there is involvement of the inferior frontal gyrus, what can we expect? Right now, if for the structure, so is the lateral sulcus here. This is the inferior frontal gyrus. Inferior. This is inferior frontal gyrus, and inferior frontal gyrus contains Broca's area. This is Broca's, and Broca's area is also known as motor speech. Clear? So, if there is involvement of the inferior frontal gyrus, what will happen? Patient will have affection of the motor speech. Yes, perfect. Right. So, now we can just take few words about aphasia. Yes. Aphasia means this is the disorder of speech. Again, we have two types, can be motor, can be the motor is also known as non-fluent, and this is also known as fluent. It's also known as Broca's, it's also known as Wernicke's. Now, what happens? Motor area is about, the expression, and Wernicke's is about perception. So, if there is any damage to the Wernicke's area, what will happen? Patient will not understand what is being asked. So, impaired comprehension. The patient will not understand what is being asked, but whatever he will say, the speech will be fluent, but not related to the question. Clear? So, the patient will speak very smoothly, but it won't be related at all to the question, because the point or the area which is concerned with the understanding of the question is damaged, right? So, speech is fluent but no way related. In cases of motor aphasia, patient will understand the question nicely, but he will not be able to reply in a fluent speech. Right? So, non-fluent speech, but answer is related to the question. Clear? So, in Broca's, he will reply, yes, you can say word salad. So, this is in short about aphasia, and of course, the location of this is inferior frontal, and the location of Wernicke's area is superior. Clear? Please remember this much related to aphasia. Now, next question. There is a case of head injury. The person can write normally, can copy easily, but is not able to speak fluently. What can be the site of lesion? I think everyone can answer this. This is Broca's area, because there is non-fluent. Thing doesn't need any more discussion. Which is not seen at high attitudes during the process of acclimatization. So, not seen at the high altitude. Yes, whenever we go to the high altitudes, body needs more of oxygen, because the partial pressure of oxygen is less at high altitudes. Especially if you have ever gone to Ladakh, you must have felt that. So, what? Yes, hyperventilation is, you need to hyperventilate. So, not hyperventilation, there has to be increased ventilatory rate, that is hyperventilation. Here, it's not hypo, it should be hyper. Yes, everyone is right. Now, what is this Bainbridge reflex? What is the effect of Bainbridge reflex? Anyone? Yes, Pratisha, you're right. What is the effect of Bainbridge reflex? Bainbridge reflex finally leads to tachycardia, right? So it will finally lead to tachycardia. So whenever there is increase in blood venous return, there is inhibition of the parasympathetic activity in terms of inhibition of the vagal tone, and this ultimately leads to increase in heart rate. Right? So this is the effect of Bainbridge reflex. Thermoregulatory center. It is present in which part of the brain? Hypothalamus. Yes. So hypothalamus has two areas which specifically relates to the temperature, high temperature or low temperature. If there is low temperature, this will lead to shivering. This is controlled by posterior hypothalamus, and if the body is exposed to high temperature, there will be sweating. This is controlled by anterior hypothalamus. So hypothalamus, it has the thermoregulatory center, and it determines the body response to the temperature to which the body is exposed. Low temperature, shivering, that is for generation of heat, controlled by posterior, and sweating to lower down the body temperature, controlled by anterior. Now, what will be the effect of low temperature on oxygen hemoglobin dissociation curve? Low temperature will shift the curve to left, and when I say the curve has shifted to left shift means what will happen to the oxygen? Will it be still attached or will it be liberated? Oxygen remains bonded to hemoglobin. Right? So there is no release. And if I say right shift, it means the oxygen will be liberated. Very good. Oxygen is liberated or released from hemoglobin. So depending on the conditions, yes, left favors affinity, very good. So left shift, it means it will remain attached. And right shift, where we can find the right shift? What are the conditions? Like especially if there is increase in PaCO2, which will lead to fall in pH, or size which increase to 3 NEETPG, anemia, raised temperature. So all those conditions will favor release of oxygen from the hemoglobin, or we will say that the curve has to right, and all the opposite conditions will shift the curve to left. So this is right shift or left shift of the oxygen hemoglobin dissociation curve, and the shape of oxygen hemoglobin dissociation curve is sigmoid. You can say S shaped curve. Now, which of the following explains the delivery of oxygen in fetal circulation? Which of the following rules explains the, yes, Krishna, you are right. Delivery of oxygen in fetal circulation is no, this is about delivery, means curve will shift. So this is the shift of curve, and related to HPF, it has high affinity force, high affinity for oxygen, and it will shift curve to left. Here will shift the curve to left, but here the factor which is responsible for release, and that is because of increased PaCO2, which leads to fall in pH, and this results in right shift of oxygen hemoglobin dissociation. So this is Bohr effect. This is how the oxygen is released. So please remember Bohr effect, and this causes, right, hemoglobin. Clear? Dopamine in low doses causes, what is the effect? We take dopamine, effect varies as per the dose. Low doses, high dose. What is the effect of dopamine in low dose? Anyone? Yes, anyone? In low dose, it causes renal vasodilation. It is renal vasodilatory in low doses. And what is the effect in high dose? High dose, it is positive inotropy. Right? So low doses, it is renal vasodilation. And what do you mean by the word inotropy? Inotropy means force of contraction, heart, especially left ventricle. Right? So if we say positive inotropic effect, it means it will increase the force. So this is in relation to dopamine. The effect varies with the amount of dose. Now, next question. A 5-year-old boy is having difficulty in walking, right? And when he was 4 months ago, his mother realized that he is having trouble in rising from the floor. This is important. Calves are bilaterally hypertrophied, and whenever he rises off the floor, he supports himself with his hands on the thighs. Now, which substance deficient? Clinical presentation for Duchenne muscular dystrophy, DMD. What should be the answer? Dystrophin gene. Right? So, in the clinical presentation, you are getting two important points. Number one is this, and number two is, now what is number one? Calves are bilaterally hypertrophied. Very good, Pratyusha. Now here, the size of the calf muscles is more, but if you check power, less power, right? So therefore, this is known as pseudo hyper, because usually what happens, size of the calf muscle or any muscle is more, the power should also be more. But here what is happening, from a distance the calf muscles are looking very bulky, but when you will check power, it is going to, so we have used the terms number one. Now what is this number two? Number two is a classical sign of Duchenne muscular dystrophy. And what is this sign? Anyone? This classical sign? Power sign. Power sign. And this is the classical way of patient getting up from the floor. Whenever he will stand up, firstly he will take the support of the floor, then he will take the support of the knees, and then only he will be able to stand up erect. So it feels patient is climbing over himself. This is the usual description, that unique way of getting up from the floor. So these 2 points are very important for Duchenne muscular dystrophy. Now next question. A lady was watching TV for long hours and she kept her hand under the head. Later on, she developed tingling sensations. Now, which nerve fibers will be affected. Now here, this is actually the pressure effect. So this is the pressure effect, and we have the sequence in terms of susceptibility to pressure, and that is sequence is ABC. So the answer would be fibers type. So A fibers are most susceptible, followed by B. The answer is A. Right now, if you remember about A delta fibers, what are A delta fibers? A delta fibers, they are mediator for fast pain, and C fibers, it is mediator for. Right? So A delta carries fast pain sensations, C fibers. Very good. So pressure, remember the sequence AB. Right. Now, which protein prevents contraction of a skeletal muscle by binding on the active sites of? Yes, Pratusha, you are right. See, if suppose this is actin, and now actin has some active site. These are active sites, and for contraction to take place, the myosin head, myosin for contraction to take place, the myosin head should bind with these active. Now at rest, when there is no contraction, there is a protein which is covering these active sites. At rest, there is a protein which is covering these active sites, and that is known as tropomyosin. So tropomyosin covers the active sites of actin at rest, and therefore it prevents contraction at rest. Right? Otherwise, if there is no protein, the myosin head will bind with actin, and that will lead to muscle contraction even at rest. So normally, this contraction process prevented at rest by tropomyosin. And yes, once there is a command for muscle contraction, the calcium will be released, and that will bind to troponin, and that will remove this tropomyosin from here, and that will expose the active sites so that the myosin head can bind with those active sites, resulting in muscle contraction. So the one which is preventing muscle contraction at rest is tropomyosin. Clear? So this is tropomyosin. So if you can look in the image, this is tropomyosin. This pink colored structure is tropomyosin, and these blue dots are actually the active sites, and these is actually the actin. Clear? So whenever there is muscle, whenever there is a stimulus, calcium is liberated. This calcium binds with troponin, and that displaces the myosin, exposing the active sites. So you can see the active sites are exposed. Now the myosin head can bind easily. Clear? So the answer has to be tropomyosin. Now next question. What will be the effect over GFR if there is a fall in efferent arteriolar resistance? What will be the effect of over GFR if there is a fall in efferent arteriolar resistance? Now, let us draw a diagram for this. Suppose this is glomerulus. Here is afferent arteriole. This is efferent arteriole. Then this is all here like this. Now, the question is about fall in efferent arteriolar resistance. It means there is dilatation of efferent arteriole. Fall in resistance means there is vasodilation. Now, if there is vasodilation, it will promote flow of blood. Therefore, GFR will decrease. There will be a fall in GFR. Here, if there is vasodilation of efferent, it will lead to decrease in GFR because blood will flow out from the glomerulus very easily. Now, on the other hand, just reverse it. If there is an increase in arteriolar resistance of the efferent, it means there will be contraction or there will be narrowing. So, the blood will remain in the glomerulus for a longer period of time. So, that will lead to increase in GFR. Right? So, efferent vasodilation, fall in efferent vasoconstriction will lead to increase in. Now, reverse the parameters for afferent arteriole. Right? So, if in afferent arteriole, the afferent arteriole, if there is vasodilation, it means there will be more blood. So, this will increase GFR. And if there is vasoconstriction, there will be less blood flow to glomerulus. So, there is less. Clear? So, please remember this relationship of afferent or efferent arteriole with respect to the state of their muscular activity, whether there is vasodilation or whether constriction. Clear? So, there will be a decrease in. We can take a 15 minutes break here and then we will continue. Right? So, a lot of stuff ending. We can take a 15 minutes. See you on the other side. Okay, dear students, welcome back. And starting again, now there was one question pending for physiology, and that was about the skeletal muscle contraction. And when does the skeletal muscle ends? This ends when there is decrease in calcium outside reticulum. So fall in calcium outside reticulum ends the muscle contraction. Now, just in brief, we can take the changes in the sarcomere at the time of muscle contraction. Yes, you are right, Rakesh. So, during a muscle contraction, if we look at the histology of the sarcomere, we know that there are three important areas. Is myosin, is also known as the dark band. So, this myosin, then there are red lines, something, and then we have thin filaments. The entire length of myosin, it is known as the A band. Entire length of the distance between the tip of two thin filaments is known as, and the distance between the tip of two myosin filaments known as. Yeah. So whenever there is muscle contraction, there is no change in the length of myosin as such. So it means A band remains. What narrows down is H zone, and the during muscle contraction, A band remains as it is, but H zone, A band, it shortens, narrows down. Please remember, in relation to muscle contraction, which is the sliding actin filament theory, muscle contract. Here, now we can move ahead to pathology. A lady came with the history of knee joints, and on microscopic examination, you saw needle-shaped crystals which are negatively birefringent. What is this condition? Yes, totally right. This is gout. Negatively birefringent needle-shaped crystals. And what is the arrangement or the shape of crystals in pseudo-gout? Yes, positive birefringence, and these are rhomboid shape. So if we wish to differentiate gout from gout, we have to few terms. Number one, the commonly involved joint involved in gout. Which joint is commonly involved? Is first grade 2. In cases of pseudo gout, larger joints are commonly involved. Is knee. Number one. Number two, on microscopy, the shape of it is, yes, very good, Nidhi. So in case of gout, it is needle shape, whereas in pseudo gout, rhomboid shape. So this is negatively birefringent in gout, birefringent pseudo gout. Then the substance in cases of gout, it is monosodium rate, whereas in pseudo gout, it calcium pyro. Here, so please remember at least these 3 points whenever we are differentiating pseudo. Yeah. So whenever you find the word negatively birefringent, think of gout. Now here the confusing point was knee joint pain, because knee is commonly involved in pseudo gout, but going with the other features, case is more suggestive gout. Yeah. Yes, Pratisha, you are right. Now another question: dystrophic calcification. Dystrophic calcification. Yes, Rinkesh, Pratisha, Nidhi, Raghu, everyone is correct. The answer is arthrosis. Again, also ABCD, Chiki. Again, we have to distinguish 2 conditions. One is dystrophic calcification. Another entity, metastatic. There are 2 points based on which we differentiate these 2 conditions. Number 1 is the status of, and number 2 is the calcium levels. So in dystrophic calcification, the tissue is dead or degenerated. In metastatic calcification, the tissue is normal. And then in cases of dystrophic, calcium levels are normal, but in metastatic it is. So this is how, based on these 2 points, you can differentiate it from metastatic. Yeah. So dystrophic in atherosclerosis. So any condition which will cause raised calcium levels, it can be hyperthyroidism, that will lead to metastatic calcification. Just the basic difference between. Now, next question. A known case of diabetes mellitus. He had pigmentation over the arm, and he is also having micronodular losses. Biopsy is showing iron deposit. Most likely, yes, everyone is correct here. The condition is hemochromatosis, and in hemochromatosis, what you see that there is pigmentation. There is pigmentation. Usually, this is bronze, brown colored. There is diabetes mellitus. Therefore, collective term is bronze. We also use the bronze diabetes, and yes, there is of iron load, which is on iron deposits. Patient can have micronodular, in which the size of nodules is less than 3 millimeter. This is micronodular. Yeah, so this is hemochromatosis. And hemochromatosis can be primary or it can be secondary. Primary, and there is no specific cause. Secondary, it can be because of if so this is hemochromatosis. Very good, Raghu, very good. Now next question. Patient has massive splenomegaly. PLC was more than 88,000 cubic millimeter with immature cell. Philadelphia chromosome was also present. What kind of mutation you will see? Clinical condition in consideration is, this is which condition? Answer is A. Of condition is very good. So condition is CML, and characteristically you can see a massive enlargement of the spleen, so massive splenomegaly. In Philadelphia chromosome is 22. So this is a balanced reciprocal translocation. Means yes, from 9 some amount part will go to 22, and from 22 equal part will come 9. So that ABCL BCR translocation. That is very suggestive of yes, ABL BCR translocation. P99 to. So this is typical description for CML. Always and always you will see splenomegaly. Next question. Certain tumors secrete some chemicals or hormones which can affect various functions of the body. This is known as, yes, this is known as paraneoplastic syndrome. And to understand paraneoplastic syndrome, especially is related to lung tumors, sometimes they release a hormone, a substance that is known as PTHR. Is growth hormone related in the action of this substance is similar to parathormone, which is normally released in the body, right? So parathyroids are normally releasing the parathormone, and this tumor is also releasing a substance which is acting like a parathormone. What will happen? The activity of two will lead to cis activity parathormone that will manifest as hypercalcemia. Clear? So the parathyroids, they are working normally. It is just because this tumor is also secreting a substance identical to parathormone. So there is overactive parathormone. Yes. So we can see any sort of syndrome. Just an example to define paraneoplastic syndrome, and especially related to squamous cell carcinoma of lung. This is paraneoplastic activity. Paraneoplastic. Next question. What we will see in a case of sickle cell anemia? Yes, glutamate to valine at beta 6 of hemoglobin. So in beta chain at 6th position, there is replacement of glutamate by valine. It is known as point mutation, and absolutely right. So this is point mutation resulting in hemoglobin S. Point mutation. Which of the following is not true for anemia of chronic disease? Which of the following is not true for chronic diseases? Yes, Raghu, Nidhi, yes, if you are correct. Raised total iron binding capacity. It is a feature of iron deficiency. Very good, Raghu. So, raised TIBC is a feature of iron deficiency anemia. Just raised, this is a feature of iron deficiency TIBC. Just remember ADA. Now, which of the following can lead to transitional cell carcinoma of urinary bladder? Which, now the term is transitional cell carcinoma. Now, this schistosomiasis is not the right answer to this condition because schistosomiasis leads to squamous cell carcinoma urinary bladder. Answer here is to naphthylamine toxicity. Here, right? So, yes, true naphthylamine toxicity will lead to transitional cell, and schistosomiasis results in carcinoma of the bladder. Okay? So, don't mix up, please. Next question. Elderly male, low back pain, there is bony lytic lesions, raised serum calcium value, and on electrophoresis, we see that albumin is not, but gamma globulin is increased disproportionately. What is this condition? Yes, everyone is right. The condition is multiple myeloma. So, again, you can see elderly person with low back pain, then bony lytic lesions, that is, if you do skull X-ray, you can see out lytic lesion, right? There is hypercalcemia, this hypercalcemia, raised gamma globulin electrophoresis. All goes in favor of multiple myeloma. Clear? Then next question. A hypertensive lady has skin hyper. He had high cortisol levels even after giving a high dose of dexamethasone. What can be the reason? This. Now, here again, you have to, everyone is right, you have to apply the concept of paraneoplastic activity. In is happening that, of course, this is a classical case of Cushing syndrome. It seems a classical case of Cushing. But even if we are giving high dose of dexamethasone, cortisol levels are not decreasing. It means the ACTH is coming from where else, which is not controlled by the pituitary system. Right? So it means it is coming from some other place, and that is ectopic ACTH secreting tumor. So this is again a paraneoplastic activity. Normally, what happens if we give high dose of dexamethasone? It should suppress the axis. So if there is no suppression of this, yes, lung carcinoma is right. So this is ectopic ACT secreting. No response to high dose dexamethasone test. One kidney is normal, another is contracted with scars. What will be the diagnosis? One kidney is normal, another is contracted with scar. Kidney is contracted with scar formation, shows previous episodes of infection? Can you answer? Will be the answer, better answer here? Chronic pyelonephritis. One kidney is not affected at all. Chronic pyelonephritis is the right answer. And you can see small kidney with multiple are. Other kidney remains unaffected here. That is very important one. Only the infection, only the kidney which has undergone infection will be shrunken and it will show scar or pits the surface. Another question, patient is having hyperpigmentation and there is high risk of development of skin cancer. What could be the answer? Firstly, tell me what condition you are thinking of. Yes, Rinkesh, you are right. What conditions you are thinking? That is right. Xeroderma. Right. Condition in discussion is xeroderma pigmentosum, and which is because of the defect in nucleotide adhesion repair, and they have this development in cancer. Right. So xeroderma pigmentosa. Then next question, 15 years old girl with weakness and she had pallor, icterus, spleen is palpable, normal MCV, increased and reticulocytosis. Osmotic fragility test is positive, Coombs is negative. What can be our diagnosis? So let us evaluate the words. There is LR, it means low hemoglobin. It is icterus, it means there is jaundice, which suggests there is increased bilirubin. And what is the source of bilirubin? Bilirubin is actually coming from breakdown of. So it might suggest that this is breakdown of RBC. Then the spleen is palpable. It means spleen is enlarged. It is being more than normal MCV, raised MCV. Now MCV suggests what? MCV suggests size of RBC, and MC is the contrast. So normal MCV means the size of the RBC is normal, neither it is small, neither it is. And if I say increased MCSC, means the cells are more darker or lighter. Yeah. And then reticulocytosis is again one more feature of hemolysis. Means the body is producing more RBCs, time to compensate for the loss of RBCs. Because now osmotic fragility test is positive, it means when the RBCs are placed in NaCl solution, they are liable to get hemolyzed. And Coombs test is negative, it means there is no antigen or antibody mediated destruction of. So the RBC destruction has no immunogenic role. Now with this all presentation, the best answer which we can make out is hereditary spherocytosis. Right? So this is hereditary spherocytosis. Because MCV is normal, so we can rule out anemia. Coombs test is negative, so we can rule out autoimmune hemolytic anemia. G6PD deficiency is especially that may result in hemolysis drugs like primaquine or depth. So better answer comes out to be the spirocyte. Much of this we have part 1 like on days. Okay. So this is hereditary spherocyte. Next question. Lady has breast cancer and the biopsy is showing tumor cells with signet ring appearance with mucin deposit. Indian file pattern. What can be the diagnosis here? This is invasive lobular carcinoma. So don't go with the word mucin deposition. Only you have to take this word into signet ring appearance and Indian file pattern. This is invasive lobular carcinoma. Now, for this invasive lobular carcinoma, you have to remember one more thing, that it can be bilateral. So, if you see a patient having a tumor in, suppose, the right breast, and on histopathology, if there is the lobular variety, then do not forget to evaluate the left breast as well, because it can be. Now, what actually is this signet ring appearance? Thing like nucleus is here. This is the signet ring appearance. Here, look in the page, signet ring. Invasive lobular carcinoma. Yes, nucleus at the periphery. Signet ring. Now, a patient having jaundice has high levels of unconjugated bilirubin. What can be one? Very good. This is Gilbert syndrome. And we take the metabolism bilirubin. What happens whenever there is, will liberate hemoglobin. Hemoglobin is liberated. Now, globin goes to the gene pool. Heme is broken down into biliverdin and finally into bilirubin. Here, now this bilirubin is taken to liver, and once conjugated, it is sent through common bile duct in part of duodenum. Here, this is the root. So, if it remains unconjugated, then we will say that it is unconjugated bilirubinemia. This is seen in Gilbert. Here, unconjugated. Just remember two conditions. One is Gilbert, another is Crigler-Najjar. So just remember two conditions: Gilbert and Crigler, unconjugated. Of course, you can remember hemolytic as well as physiologic jaundice. Next question. Characteristic feature of hemolytic anemia. Anyone? When we say hemolytic anemia, RBC are bent down and products leakage, they binds with, right? What should happen to haptoglobin? Levels of haptoglobin, because it is all utilized. What will happen? Decreased hapto. Okay? Perfect. Decreased haptoglobin, feature of hemolytic. Next question. Lady with weight gain, constipation, lethargy, and hoarseness of voice, and she is having anti-thyroid peroxidase antibodies. What will be your diagnosis? Yes, Raghu, you are absolutely right. This is Hashimoto's thyroiditis. Now, the classical presentation, if you see here, weight gain, constipation, lethargy, this is existing hypothyroidism. So, Hashimoto's thyroiditis classically presents as hypothyroidism. Just this is Hashimoto's thyroiditis. Going to the next question. Hemoglobin is 9%, MCV is 65, RBC distribution weight is 6, platelet is okay. What additional finding will you see in patient? So in such a case, first you have to make your diagnosis. Yes, right. So see, this is hemoglobin is less, MCV is also less, this is high. So this goes in the case of iron deficiency anemia, and in a case of iron deficiency anemia, you will see raised PI. Perfect. This is raised PIBC. MCV, the normal value is in 80 to 100. Should be, and red blood cell distribution width, it should be around in how you can remember. Now, next question. Lady has a malar rash, is positive anti-Smith antibody, and there are small sterile nodules over the heart wall. What is the condition? SLE, because you can see here this is by rash, the Smith antibody. We have typical on either side of the heart valve vegetations. This is the ligament sac. Classical presentation. Next question. In a person who is having progressive renal failure past 3 years, we can see glomerular and vascular deposition of pink amorphous material which shows apple green birefringence under polarized light with Congo red staining, which are positive for lambda light chains. What can be diagnosed? Yes, the condition is amyloidosis, but it is seen in which of the following option? This is multiple. This is multiple, and here you can see that the person is going into chronic renal failure. This description is again amyloidosis. Yeah. So this is primary variety. You are saying amyloid light chains, AL, primary amyloidosis. Now, if we talk about the tuberculosis thing, this can give rise to amyloidosis, but that is in secondary amyloidosis chains. Okay. This is secondary amyloidosis. In fact, secondary amyloidosis is seen in chronic inflammatory condition. In which conditions we can see chronic infections like tuberculosis, chronic bronchitis, bronchiectasis. So this is secondary amyloidosis. Yes, Raghu. So, and double A. Next question. Lady is having progressive dysphagia. We have thickening of the oral mucosa, whether like she is hypertensive with limited exercise capacity because of lung fiber. What can be the diagnosis? Yes, this is scleroderma. This is a classical picture, scleroderma. You can remember the crest syndrome, sclerosis as well. Thickening of skin. Yes, it has been mentioned, leather like. Next question. Patient has, a lady has, very important, erythematous butterfly rash, cheeks. Which antibody will you in this case? Yes, this is very basic, anti-double stranded DNA. Typical case of skin, case of you will find anti-double. Next question. Chronic smoker have intermittent claudication. Initially the pain was at movement, but now it is also happening at rest. So what is the diagnosis? I think everyone can answer this. This is Berger disease or trans. In first session, we have already discussed the concept of claudication. Now the patient has gone into rest. Here, so this is Berger disease and smoker male. Next question. 6 years male child with sore throat, developed hematuria. Vitals were normal, and parents said the urine was like most likely diagnosis. Classical description for PSGN. There is a history of sore throat and hematuria, that is nephrotic syndrome. Classically, the color of the urine is like cola colored nephrotic syndrome. And next question. Elderly patient has been working in the dye industry for over 30 years. Now he is having some symptoms related to urinary bladder like hematuria, frequency, urgency. What can be the condition? Everyone is right. This transitional cell carcinoma of urinary bladder, and frequency means increased number of times patient has to urination. What is this word? Urgency. He can't tolerate. He will rush for urination. These are the two terms. Then again, if you find the term squamous, your answer has to be, your condition has to be cystic. Just make sure aniline dye. This is classical description, transitional carcinoma. Patient is working high industry. Next question. Child is having fatigue, lethargy, pallor, and he is a known case of iron deficiency anemia, who is already taking medication. Now, before starting IV iron supplementation, what investigation you would do? Yes, everyone, right? We will go for ferritin. And why ferritin? Because ferritin is the iron. They are the iron, yes, storage form of the body, and that specifically reflects the amount of iron in the body. Ferritin has to be done. And if needed, then only go for any IV supplement. Ferritin, check ferritin. Next question. A patient had died because of suspected MI, and when you will do biopsy, you will stain the heart tissue with TTC, that is triphenyl tetrazolium chloride dye. Now, the viable myocardium means not dead. How it will appear? Yes, it will appear red, and the dead will appear slightly pale. Look here, this is all normal, the viable myocardium, and this is octave area. Okay? So this is with TTC, meaning heart with TTC. Okay? Yes, of course, this is coagulative. Next question, we have already discussed in first session. Elderly male with low back pain, osteoblastic injuries. What will be your answer? Everyone can answer nicely. This is carcinoma prostate, because usually the osteolytic, but in carcinoma prostate it is plastic metastasis. Yeah. Next question. Patient had, when you do blood parameters, you found that MCV was less, MCHC was also less. Now, what kind of anemia is this? If MCV is less, it means the RBC are of small size. If MC is less, RBCs are being less contrast, means they are hypochromic. Here, this is microcytic, this is hypochromic. So answer will come out to be hypochromic anemia. Yes, everyone is right. This is microcytic hypochromic. Now, next question. Elderly patient with thrombocytopenia, neutropenia, and erythrocytopenia. All the cell lines are decreased. Screen was massively enlarged. There is high number of blast cells, and what translocation can you expect? Yes, the classical case of CML, we will expect of 9 to, very good. This is CML. The moment you find massive enlargement of screen in relation to any leukemia, always think here it has to be. Next question. Lady with abdominal mass investigated, and she was found to have bilateral ovarian masses and surface is smooth. And when surgical examination was done, we found that there was mucin secreting cells with signaling appearance. What can be the diagnosis? Very good, Raghu, very good. Ruckenberg tumor, and this is actually no, this is the typical signet ring appearance. We can see the nucleus which is at one corner, one portion appearance. Now, what is Krukenberg tumor actually? Suppose this is stomach. Lower down we have three. What happens? Tumor cells of the stomach can directly drop to the surface of ovary. Therefore, the signet ring is having same resemblance as that of the malignancy. So the tumor cells are directly dropping over the. This is tumor which is metastasizing in a very unique manner. It is directly dropping over of ovary, and therefore surface remains. So this is Krockenberg tumor, and please remember the signet appearance. Very good. Now the next question. There are electron dense deposits with hylinosis and sclerosis with diffuse loss of foot processing. Here, if you simply focus on diffuse loss of foot processing, might be wrong. You have to consider hylinosis well. Therefore, your answer will become yes. Very good. Consider both the entities. So, hylinosis with, you can see this is hylinosis, and there is effacement of the foot processes, podocytes. That is FS. Please, yeah, you're right. Now, next question. A patient presented with arthritis, enlargement of liver and spleen, increased pigmentation, and raised serum ferritin levels. What diagnosis can? Yes, this is again a classical presentation for hemochromatosis. There is arthritis, enlargement of liver, spleen, increased pigmentation, brown colored pigmentation with excess iron storage, that is ferritin. This is hemochromatosis. Wonderful. And next question. 35 years with bleeding gums and fatigue. There is marked leukocytosis in 70% of the cells. They are having myeloperoxidase positivity. Very good. This is classical description for AML. And remember, this age is very important here, because many times the AML and ALL, they have the same time of clinical presentation. It is just based on the age we can differentiate, because ALL is commonly seen in the childhood and AML in adulthood. And of course, this is myeloperoxidase positive. You can see also roads as well. This is AML. Yes, AML. Chronicity is very usual presentation of hepatitis. One usual presentation of, very good, this is hepatitis C, and in hepatitis C we rarely see acute presentation, and just because it is a chronic condition, sometimes most of don't even know whether they are with hepatitis C. Yes, very good. You can say C is better than, because some cases of can go into chronic phase, but majority they recover. C is better answer, better than. The next question. Patient presented with hemoptysis and hematuria, and there is antibodies against glomerular basement. What is the answer? Yes, everyone is right. This is good Pasha syndrome. So here we have anti-basement membrane antibodies, which principally affects lungs, knees. Therefore, the patient will develop crisis out of blood and maturia blood in it. So, good posture, very good. Next question, ground glass hepatocyte. The moment you find the word ground hepatocyte, the answer has to be is hepatitis ground glass hepatocyte. Next question, a patient with cancer of bowel developed massive proteinuria and there is subepithelial deposits. So there is massive proteinuria and subepithelial deposits, and this is feature of, if you just focus on massive proteinuria, you might be wrong. You have to take this fact into consideration also. So the better answer will become membranous glomerular. So you can see there is deposition immune complexes that give rise to the subepithelial, not NCD, because important feature given is subepithelial deposit is membranous glomerular MGN. If you stick only to massive proteinuria, you might be wrong. You have to look for subepithelial deposit as well. Yes, in minimal chain disease, what if you do light microscopy? What are the findings on light microscopy? It is absolutely normal, and therefore this condition was erroneously named as minimal chain disease by just looking at the light microscopic features. But when same slide was connected to electron microscopy, it was noticed that there is basement footprint. Right? So just looking at the light microscopy, it was normal, so it was called as minimal chain disease. Right? Was the history behind this nomenclature. But electron microscopy, you will see that the foot processes, they fuse, flatten. Subepithelial deposit, please remember MGN. Yeah. Next question, everyone can answer this. We have already discussed where we need to remove the spleen. When we should remove the spleen, first session is hereditary spherocytosis, the condition where the RBCs are spherical in shape. As they try to spleen, they are broken down. So if you want to prevent hemolysis, you have to sacrifice spleen, right? So splenectomy should be done in, again, with the preoperative pneumococcal vaccination. Next question, there is history of jaundice for 10 days. Bilirubin levels are high, SGOT, SGPT are high, alkaline phosphate is high, and the patient is positive surface antigen. If you want to make a diagnosis of acute hepatitis B infection, what other thing you should check in the patient? Yes, you can go for anticore antibody, and even DNA PSR is also okay. We have two good there in ANC, both can be the answer. Both can be the answer. But whenever we do, we commonly follow this. in routine clinical practice, we routinely do anti-HBC variety for recent. We can also do HBV DNA PCR, which also tells about the infectivity. But clinically, we prefer IgM anti-HBC. Can do either of the two, but routinely we do IgM anti-HBC. Clear? Next question. A young male presented with history of infertility, recurrent episode, itis with bronchiectasis, and situs inversus. And this is very basic. This is Cartagener's syndrome. And what is this situs inversus? I think everyone must be knowing it. Organs change their side. Means the heart will towards the right side, liver will go on. So side is changed. And there is bronchiectasis, that is normal dilatation. Sinusitis, infertility, ineffective ciliary motility. So this is Cartagener. Yes, Aninda, you are right. They are on the opposite. Next question. Surface antigen is positive. IgM anti-PC is positive, and envelope antigen is also. What will be the diagnosis? Surface antigen, then IgM anticore antibody, and also envelope antigen is positive. What does this mean? Very good. Means these two say that the patient is having acute virus, and this tells us that the patient is highly high viral load. The better answer will come out to be acute infection with high infection. Here, next question. Years old child with hematuria and RBC cast in urine. Basic. The answer would be hematuria, RBC cast is PSGN. This is nephritic syndrome. PSGN. Very good. Nephritic syndrome. Then during the window period of AIDS, what diagnostic test? Window period, then around 3 months time. The answer is PCR. The routine tests like ELISA, Western blot, they are not positive during the window period. So RT, PCR, and we can also go for P24 antigen, but the best is RT. During window period, ELISA, Western blot, they are negative, right? So best is RT. RT-PCR seems a better answer here. P24 can be done. So this is the end of the pathology. Now we can have a lunch break. Not actually 15 minutes break. We can longer breaks. So see you on the other side of the break, and then we will start with pharmacology. See you.